So very good afternoon to all of you. I am talking about management approach to a non-healing corneal ulcer. I have no financial interest. So corneal ulcer is defined as loss of surface corneal epithelium along with infiltration into the surrounding and underlying layers. And non-healing or recalcitrant corneal ulcer refers to a corneal ulcer which does not respond to the conventional treatment. Response of a corneal ulcer to a treatment is indicated by a decrease in size of epithelial defect or infiltrates. The time frame for resolution differs for various etiologies of a corneal ulcer. Like in case of bacterial or viral corneal ulcer, after starting the treatment, even after 48 hours of initiation of specific antimicrobial therapy, if the ulcer is not resolving, there is no sign of improvement, then we label it as a non-resolving. And in case of fungal corneal ulcer, this time period extends up to the 5 to 6 days. Initially, even if no further progression in ulcer dimension itself highlights responsiveness of treatment to the ulcer. Any increase in dimension, non-localization of margin of the ulcer, fuzzy ill-defined borders, increase in slough are indicators for non-responsive ulcer in the treatment. When patient is followed on daily basis, worsening of the above parameters in 8 to 72 hours indicate ulcer is not responding to the treatment and need for revised diagnosis or revised medications. So there are various causes, like most important cause is incomplete treatment or non-compliance of the patient. Other causes are epitheliotoxic drugs, inaccurate diagnosis, drug-resistant microorganisms, atypical microorganisms, advanced severe corneal ulcers, ulcer with impending perforation or already perforated ulcers, retained foreign body, posterior segment involvement with endophthalmitis, and immunocompromised state. Other systemic causes like diabetes mellitus are also there. Some adnexal abnormalities like entropion, entropion-otrichiasis, leg of thalamus, dacrocystitis, any coexisting thyroid eye disease, and mechanical trauma to the cornea in the form of papillar follicles in upper lid in palpebral conjunctiva. So the ulcer usually presents with acute red eye with pain, photophobia, and vision loss. There may be history of trauma with vegetative material or febrile viral keratitis. There are nature of pain also indicates the diagnosis of the organism. Like in bacterial keratitis, there is significant pain. In fungal keratitis, there is no severe pain. In acanthiva keratitis, there is severe pain owing to the radial keratoneuritis, which is usually out of proportion to the size and extent of the ulcer. In herpetic dendritic ulcer, there is minimal pain. Corneal trauma by vegetative material may indicate towards the mycotic ulcer. Prolonged contact lens wear, especially overnight or extended wear soft contact lens, may indicate towards pseudomonas species. Exposure to the dirty swimming pool water or pond water and contaminated contact lens solution may indicate towards the acanthiva keratitis. If there is dacrocystitis, then there may be chances of pseudomonas keratitis there. So medication prescribed earlier for the ulcer needs evaluation. Like most of the cases who presented in this region are taking topical corticosteroid, which worsen a case of probable mycotic keratitis rapidly. NSAIDs worsens the corneal ulcer and causes corneal melts. So we have to check all the medications which patients are taking priorly. History of any previous ocular surgery include cataract and refractive surgery should be taken off. In visual acuity should be checked. In central or large corneal ulcer, significant impairment of visual acuity may be there. And adnexal abnormalities must be checked for any eyelid malpositions, any adnexal abnormalities, other any conjunctivitis. In coming to the cornea, examination of cornea proper, first we have to see the location. If there is isolated peripheral ulcer, then there may be chances of herpes simplex virus or mycobacterial tuberculosis. If dry looking ulcer with feathery marginal satellite lesion, there may be chances of mycotic keratitis. Dendritic ulcers are seen in herpes simplex keratitis. Ring ulcers are seen in acanthiva keratitis, and bacterial ulcer are usually wet looking with punched out appearance. Margin of ulcer, in case of peripheral ulcerative keratitis, overhanging edges are there, and that may be because of Murren's ulcer. The most important indicator of response to the ulcer is size of both the epithelial defect and surrounding infiltrates. The size, density, and depth of infiltrate is recorded in detail in each and every visit, and reference to be taken in follow-up to evaluate response of that corneal ulcer to the treatment. Corneal sensation must be checked, to particularly it is decreased in cases of viral keratitis. In anterior chamber, we have to look for hypopyon, which may be associated with any corneal ulcer. In fungal keratitis, fixed hypopyon is there that does not change position despite making the patient lie supine for at least 10 minutes. If there is posterior segment is visible, then okay, otherwise we have to do BS scan for that. Documentation of location, size, shape and visualization of corneal ulcer is very important. It becomes even more important in case of recalcitrant corneal ulcer. Colored clinical photographs may be taken, or schematic diagrams must be drawn on the paper for each and every visit. So we have to rule out any systemic diseases, especially diabetes mellitus and any other immunocompromised diseases. In ocular investigation, we look for intraocular pressure, VS scan to evaluate posterior segment. Corneal scraping should be done in case of recalcitrant keratitis. The previous treatment should be done for at least 24 hours and fresh corneal scraping should be done. If there is any conjunctival discharge or like ramal sac discharge or bandage contact lens, that is separately sent for microbiological examination. Along with culture, other microbiological investigation that need to be done includes gram staining, GIMSA staining, Gill-Nielsen staining and QH weight mount. Other specialized investigation may include confocal microscopy and serological testing, including PCR, that may also aid in diagnosis. Corneal biopsy or suture biopsy may be taken for deeper ulcers. An anterior chamber paracentesis can be done for microbiological investigation in case of hypopyon corneal ulcer. After that, we have to start with the empirical therapy like broad spectrum antibiotics such as fortified cefazolin 5% and fortified tobramycin or ciprofloxacin. Cycloplegic is used for cyclitic pain relief, and systemic antibiotics should be given in large ulcers with impending perforation or scleral involvement, and in case of posterior segment involvement. After giving those empirical therapy, once we get the culture report, then we have to start with the definitive therapy according to the culture reports for organisms, whatever organisms are there. So in case of fungal keratitis, if topical treatment is not working, then we can go for intrastomal voriconazole injection as a targeted drug delivery system. Intrastomal voriconazole in a dose of 50 microgram per 0.1 ml administered using 1 ml tuberculin syringe and 26 gauge needle. Intracameral and intrastomal voriconazole can be given if there is hypopyon is there. Amniotic membrane graft is effective alternative for treating persistent neurotrophic ulcer and non-traumatic corneal perforations and descemetocele. Tarsorrhaphy should be planned early in cases of neurotrophic cases. In non-healing epithelial defects, tarsorrhaphy is reported to have 80% to 100% success rate for complete healing. It should be performed sooner rather than later when persistent epithelial defect do not respond to the medical therapy. Collagen cross-linking is an effective procedure in treating non-resolving microbial keratitis with superficial stromal involvement. It provides early symptomatic relief to the patient by decreasing corneal sensation and hence reducing the pain. Therapeutic keratoplasty has a role in management of severe and refractive keratitis with high success rate in restoring anatomical integrity. It is indicated when their infection is clearly not responding to the conservative medical treatment, if there is threatened perforation and likelihood of spread to the limbus or sclera, endophthalmitis where it may need to be combined with vitrectomy, and in cases of threatened panophthalmitis. So these are few examples of the cases which are presented in as a non-resolving corneal ulcer, and after therapeutic keratoplasty they have done well. So to conclude, recalcitrant microbial keratitis is a challenge to every ophthalmologist. Its management involves a step-by-step approach. Timely diagnosis and intervention may save the ulcer from perforation. Timely referral is also important. Newer modalities such as collagen cross-linking, intrastomal and intracameral drug injections, and other methods of targeted drug delivery system may be tried. If the infection is clearly not responding to the conservative medical treatment, therapeutic keratoplasty should be considered. Thank you.
Thank you, Dr. ABISHRK. Excellent presentation.